Have you ever had that feeling maybe you're facing a new health situation or just really curious and you need to genuinely get a complex medical topic, not just skim it? Or maybe you've wondered how some really ancient medicines, ones people have used for ages, actually work on our bodies.
Well, that's exactly what we're doing today.
Yeah.
We are taking a proper deep dive into a really fascinating and frankly powerful group of drugs, the cholineceptor-blocking drugs.
Yeah.
And what's so interesting, I think, is they're not just some modern lab creation. Their roots go back thousands of years. We're talking plants like deadly nightshade and Jimson weed. So our mission really is to unpack these, understand exactly how they work, their specific actions, how they interact with our systems, and their incredibly wide range of uses. I mean, from treating chronic diseases right through to being absolutely vital, life-saving antidotes. We'll get into the muscarinic and nicotinic types, but we're going to focus particularly on those that block the muscarinic acetylcholine receptors.
Exactly. We're aiming to master this, really understand it like the top professionals do. We'll cover everything from the basic receptor types, their structure, all the way to how they're used in the clinic day to day, and importantly, the risks involved. By the end, you'll have a really solid grasp of how these drugs work and why knowing about them is so crucial. Okay, let's dive in. So, starting at the beginning, how do we even categorize these drugs? Broadly, you've got two main buckets for cholineceptor antagonists, right? Muscarinic and nicotinic.
That's the fundamental split, yeah. Now, the nicotinic side includes things like ganglion blockers, which honestly have very little clinical use these days, more for research, and neuromuscular junction blockers.
Yeah.
Those are super important, especially in anesthesia, but that's a whole other deep dive.
Yeah.
So today, our main focus is going to be on drugs that specifically block the muscarinic acetylcholine receptors, and we generally call these antimuscarinics.
Okay, antimuscarinic.
And, that term is actually better than, say, ParaSympatho-Lytic, because antimuscarinic tells you exactly which receptor system is being blocked. It's just more precise.
Right. Okay, so focusing on those muscarinic receptors. Here's where it gets really interesting, I think. It's not just one type of receptor, is it?
Not at all. We actually know of 5 distinct muscarinic receptor subtypes. We call them M1 through M5.
Yeah.
Scientists figured this out using some pretty sophisticated techniques like ligand binding studies and cloning experiments. And the fascinating part is, while they're all muscarinic, they each do slightly different jobs in the body. They have functional differences.
And what about their structure? What do they actually look like at a molecular level?
It's quite remarkable, actually. When you look at the X-ray structures, all 5 subtypes, M1 through M5, look very, very similar when they're in their inactive state with an antagonist drug bound to them. Think of the main binding site, the orthosteric binding pocket, where acetylcholine naturally binds. It's buried deep within the cell membrane.
Okay.
And here's the kicker. The specific amino acids right there in that pocket, they're incredibly similar, conserved across all 5 subtypes. And that's why it's been so difficult to design drugs that are really selective for just one M subtype. It's like trying to make a key for only one lock when all the keyholes look almost identical.
Makes sense.
But there's another part. There's this area called the extracellular vestibule, sort of like an entryway, and a thing called the tear lid that separates it from that main binding site.
Okay.
And crucially, this outer vestibule region is made of different amino acids in the different subtypes.
Ah, so there are differences.
Exactly. And those differences create unique spots for something called allosteric modulators to bind.
Allosteric modulators.
Yeah, think of them not as blocking the main keyhole, but binding nearby and subtly changing how the lock works, maybe making it easier or harder for the main key, acetylcholine, to work, or changing the receptor's overall shape. These allosteric sites are absolutely key because they give drug designers a way to achieve that much-needed selectivity. Smarter drugs, fewer side effects, that's the goal.
Got it. So these 5 subtypes, M1 through M5, where do we typically find them in the body? What are their main jobs?
Good question. So M1 receptors, you find those mainly in the central nervous system, on neurons there, also on autonomic postganglionic cell bodies, and at many presynaptic sites, kind of like gatekeepers controlling neurotransmitter release.
Okay, CNS and nerve junctions.
M2 receptors are hugely important in the heart. They're in the myocardium, controlling heart rate and contraction force. You also find them in smooth muscle organs and some nerve sites, too.
Heart control, primarily.
M3 receptors are probably the most widespread on effector cells. Think glands like salivary glands and smooth muscle cells like the ones lining your airways, your gut, your bladder. Very common.
Glands and smooth muscle. Got it.
And then M4 and M5 are a bit less prominent overall. They're mainly found in the CNS. There's some interesting research suggesting M5 might be involved in the complex pathways of drug addiction, but there's still more to learn there. Each one has its own niche, its own specialized role.
It's incredible how specific it gets. Now let's shift gears a bit and talk history. You mentioned these drugs have ancient roots.
They really do. It's quite amazing. People have known about and used plants containing these naturally occurring antimuscarinic compounds for millennia. As medicines, yes, but also as poisons and even as cosmetics.
Cosmetics? Really?
Yeah, we'll get to that.
Yeah.
The classic prototype drug here is atropine. It comes from plants like Atropa belladonna, that's deadly nightshade, and the turistramonium, or Jimson weed. Another really important natural one is scopolamine, which is also called hyoscine. That comes from Hyoscyamus niger, or henbane. These plants are just loaded with these potent alkaloids.
And chemically speaking, what are they?
They're classified as tertiary amine alkaloid esters of tropic acid. Looking at their structures, they have specific features that give them their properties.
Okay.
And an interesting point about atropine, what occurs naturally is actually the L-hyoscymine form. But when it's processed commercially, it tends to racemize, meaning it becomes a 50-50 mix of the L and D plus forms.
And does that matter?
Oh, absolutely. It matters hugely. The L isomers, the naturally occurring shape, essentially are way more potent, like at least 100 times more potent than their D plus mirror images. That subtle difference in 3D shape makes a massive difference in biological activity.
Wow. Okay, so starting with these natural compounds, we then develop synthetic versions.
Exactly. Chemists created both semi-synthetic, modifying the natural molecules, and fully synthetic antimuscarinics. The tertiary members, because they can generally cross the blood-brain barrier more easily, are often used for effects needed in the eye or the central nervous system. Examples would be tropicamide for eye exams, benztropine for Parkinson's-like symptoms, or dicyclomine for gut spasms.
Okay.
And what's also interesting is that many other types of drugs, things like older antihistamines, some antipsychotics, many antidepressants, can have noticeable antimuscarinic side effects.
Why is that?
Often it's because their chemical structures happen to look similar enough to acetylcholine or atropine that they accidentally fit into the muscarinic receptor, even though that's not their main job.
I see that.
Then you have the quaternary amine antimuscarinic agents. These were specifically designed differently. Think propantholine, glycopyrrolate, tiotropium. They have a positive charge.
And what does the charge do?
It makes them much less lipid soluble. So they have a harder time crossing cell membranes, especially the blood-brain barrier. The result, they tend to have more peripheral effects acting on the gut, lungs, bladder, and reduced CNS effects. A very deliberate design choice to target specific areas and minimize brain side effects like drowsiness or confusion.
Clever. Okay, so we know what they are, their history, their chemistry. How do they actually move through our bodies? Let's talk pharmacokinetics, starting with absorption.
Right. So the natural alkaloids like atropine and most of those tertiary antimuscarinics we just mentioned, they're generally well absorbed. They get into the bloodstream pretty efficiently from the gut if taken orally, or even through the conjunctiva of the eye if used as drops. Some, like scopolamine, are absorbed so well through the skin that we can deliver them via transdermal patches.
Ah, the motion sickness patch.
Exactly. That's how that works. Now, contrast that sharply with the quaternary antimuscarinic drugs, the charged ones. Because of that charge, their lipid solubility is way down. So typically only about 10 to 30% of an oral dose actually gets absorbed into the bloodstream.
Big difference.
Huge difference. And it really dictates how we use them. You wouldn't give a quaternary drug orally expecting strong systemic effects, usually.
Okay, so once they're absorbed, where do they go? Distribution.
Again, it depends on the type. The tertiary agents, like atropine, are widely distributed throughout the body. They get into the central nervous system pretty readily, reaching significant levels within maybe 30 minutes to an hour.
Which can be a problem if you don't want CNS effects, right?
Precisely. If you're trying to treat, say, gut spasms, the dose might be limited by side effects like drowsiness or blurred vision caused by the drug getting into the brain and eyes. Scopolamine is particularly good at getting into the CNS, distributing rapidly and fully, which explains why it tends to have more pronounced central effects than atropine at similar doses.
And the quaternaries.
The quaternaries, because of that charge and poor lipid solubility, are poorly taken up by the brain. So at normal therapeutic doses, they're largely free of CNS side effects. Ideal if you want to target, say, the lungs or the bladder without causing confusion.
Makes sense. And how does the body get rid of them? Metabolism and excretion.
Let's use atropine as the model. Its elimination from the blood is kind of interesting. It happens in two phases. There's a rapid phase with a half-life of about 2 hours, where the blood level drops quickly. Then there's a much slower phase with a half-life around 13 hours.
Few phases.
Yeah, and about half of the dose gets excreted unchanged in the urine. The rest is broken down by hydrolysis or conjugated before excretion. But here's the really crucial clinical point, especially for atropine. Its effect on parasympathetic function disappears relatively quickly in most organs, except the eye. The effects on the iris, causing pupil dilation, and on the ciliary muscle, causing problems with near focus, can last for 72 hours or even longer.
That's why eye drops can affect your vision for days.
Exactly. That persistence in the eye is really significant.
Okay, so we've covered the what, the where from, the how it gets around. Now, the big question, how do these drugs actually work? What's the mechanism of action?
Right, so fundamentally, it boils down to what we call reversible, surmountable blockade.
Reversible blockade, meaning?
Meaning the block isn't permanent. Think of acetylcholine as the normal key for the muscarinic receptor lock. Atropine is like a key that fits in the lock but doesn't turn it, it just blocks the hole. If you only have a little bit of atropine blocking some locks, and then you flood the system with a whole lot of acetylcholine, the acetylcholine can eventually outcompete the atropine and kick it off the receptor. The block can be overcome or surmounted.
Okay. And at a molecular level?
We know there's a specific aspartate amino acid residue in the third transmembrane part of the receptor. This aspartate forms a key ionic bond with the nitrogen atom on acetylcholine. And it turns out this same aspartate residue is also essential for the binding of anti-muscarinic drugs like atropine.
So it binds to the same crucial spot.
Pretty much. So when atropine binds there, it physically prevents acetylcholine from binding and activating the receptor. And that stops all the downstream effects that acetylcholine would normally trigger. Things like the release of intracellular messengers like inositol trisphosphate, IP3, or the inhibition of adenyl cyclase. These are key signaling pathways inside the cell that get shut down right at the source.
Stops the signal cold?
Essentially, yes. Now, here's a slight refinement based on more recent research, which really deepens our understanding.
Okay.
Traditionally, we thought of these drugs as just neutral blockers. They just sit there and occupy space. But recent evidence indicates that muscarinic receptors are constitutively active.
Constitutively active, meaning they're on a little bit all the time.
Exactly. They have a certain baseline level of activity even when no acetylcholine is around. A low hum, if you like. So it turns out that most of the drugs we call antimuscarinic blockers, including atropine, are actually inverse agonists.
Inverse agonists.
Yeah, instead of just blocking acetylcholine, they actively bind to the receptor and stabilize it in an inactive state, actually reducing that baseline hum. They turn the dimmer switch down, not just block the main switch.
That's a subtle but important difference.
It is. And regarding selectivity, atropine is very good at distinguishing between muscarinic and nicotinic receptors. It's highly selective for muscarinic.
But not between the M subtypes.
Correct. Atropine itself doesn't really distinguish between M1, M2, M3, M4, or M5. It hits them all pretty much equally. But, as we touched on, some of the newer synthetic antimuscarinics do show moderate selectivity for certain subtypes, like perinzapine for M1 or darafenacin for M3. And that selectivity is a really big deal for developing more targeted therapies with fewer side effects.
Right, because you can target the M receptor you want without hitting all the others.
Exactly. Although it's also worth noting some synthetic drugs are less selective in other ways and might also block histamine receptors or even have some ganglion-blocking activity, which adds to their potential side effect profile.
Okay, makes sense. Now let's take that tour through the body you mentioned. See how blocking these muscarinic receptors affects different organ systems, starting with the brain.
Right, the brain's response. With atropine, at typical therapeutic doses, you usually see minimal stimulant effects. Maybe a bit later on, a slower, longer-lasting sedative effect can occur.
But scopolamine is different, isn't it? More pronounced CNS effects.
Definitely. Scopolamine usually causes noticeable drowsiness, even at normal doses. And in some people, it can cause a weird kind of amnesia. There's some thought this might involve histamine H3 receptors as well.
Okay. But what about toxic doses?
That's where it gets serious. High toxic doses of either drug, but especially scopolamine, can lead to significant CNS overstimulation. We're talking excitement, agitation, hallucinations, and potentially even coma. It's a dangerous state.
But therapeutically, they are used for CNS conditions, right? Like Parkinson's.
Yes, absolutely. Centrally acting antimuscarinics have a long history with Parkinson's disease. Actually, belladonna extract containing atropine was one of the first treatments ever used for the tremor associated with Parkinson's.
Why do they help?
Well, in Parkinson's, there's a deficiency of dopamine in a part of the brain called the basal ganglia. This creates an imbalance, a relative excess of cholinergic activity. Anti-muscarinics help by dialing back that cholinergic system, trying to restore a better balance.
So they're still used.
Often adjunctively, yeah. Alongside drugs like levodopa, they can help manage the tremor. They're also quite useful for reducing those extrapyramidal symptoms, the movement side effects, like stiffness or tremor that can be caused by some antipsychotic medications.
Okay. And scopolamine for motion sickness.
Yeah.
How does that work in the brain or inner ear?
Scopolamine is really effective for vestibular disturbances, yeah, especially motion sickness. It seems to work by affecting muscarinic transmission, likely involving M3 and M4 receptors, within the pathways connecting the inner ear's vestibular apparatus to the brain's vomiting center. It might also influence the production of endolymph fluid in the inner ear. Basically, it helps calm down those, I'm moving weirdly, signals that trigger nausea.
Fascinating. Okay, let's move to the eyes. We mentioned dilation before.
Right, mydriasis pupillary dilation. That's a classic effect. It happens because these drugs block the M3 receptors on the pupillary constrictor muscle, the muscle that makes your pupils smaller.
So if that's blocked.
Then the opposing muscle, the pupillary dilator muscle, which is controlled by the sympathetic nervous system, takes over unopposed. Result, wide pupils.
And that's the belladonna connection, right?
Exactly. Belladonna means beautiful lady in Italian. Apparently, women in Renaissance Italy used extracts of the plant as eye drops to dilate their pupils, which was considered attractive at the time.
Wow. Okay. What else happens in the eye?
The other major effect is cycloplegia. This is weakening or paralysis of the ciliary muscle. This muscle is what changes your lens shape to focus on near objects.
So if it's weakened,
you get a loss of accommodation. The eye can't focus properly for near vision. Everything up close looks blurry.
And both of these effects, mydriasis and cycloplegia, are useful for eye exams.
Hugely useful. Mydriasis allows the doctor to get a really good look at the retina and optic nerve at the back of the eye. Cycloplegia is essential for getting an accurate measurement of refractive error, like nearsightedness or farsightedness, especially in kids, because it prevents their eye muscles from interfering with the measurement.
But there's a risk too, isn't there? Glaucoma.
Yes, a crucial risk. In people who have narrow anterior chamber angles, a specific anatomical feature in their eye dilating the pupil can bunch up the iris tissue in the angle and block the outflow of fluid from the eye. This can cause a sudden, sharp rise in eye pressure and acute glaucoma attack. It's a medical emergency.
So definitely contraindicated in those patients.
Absolutely. Or used with extreme caution. And another, less serious eye effect is reduced tear production, reduced lacrimal secretion. This can lead to that feeling of dry or sandy eyes, especially with higher systemic doses.
Right. Okay, let's talk heart. You mentioned atropine's complex cardiac dance. What happens there?
The sinoatrial day. As a note, the heart's natural pacemaker is very sensitive to muscarinic blockade. The vagus nerve normally acts like a brake on the heart, slowing it down via muscarinic receptors.
So blocking those receptors
Takes the brakes off. At moderate to high therapeutic doses, atropine blocks that vagal slowing, leading to tachycardia and increased heart rate.
Simple enough, but you said it was complex.
Yes. Because counterintuitively, lower doses often result in initial bradycardia, a slowing of the heart rate before the tachycardia kicks in.
Slowing first? Why on earth would that happen?
It's thought to be due to blocking projunctional M1 receptors. These are autoreceptors located on the vagal nerve endings themselves.
Autoreceptor.
Yeah, they normally act like a local feedback mechanism, limiting how much acetylcholine the nerve ending releases. So if atropine blocks these M1 autoreceptors first, perhaps because they're more accessible or sensitive at low doses, it actually removes that inhibition, causing a temporary increase in acetylcholine release right at the SA node, which leads to that initial slowing. Then, as the atropine concentration rises and blocks the main M2 receptors on the SA node itself, the tachycardia takes over.
Wow, that is complex. A feedback loop effect.
Exactly. It also affects the atrioventricular, AV node, speeding conduction through it, which shortens the PR interval on an ECG. It affects the atrial muscle too. Ventricular effects are usually minimal at therapeutic doses because the ventricles have less vagal innervation.
But at toxic levels.
At very high toxic concentrations, atropine can cause intraventricular conduction block. This is probably due to a different mechanism, more like a local anesthetic action on the heart muscle sodium channels, rather than its muscarinic blocking effect.
Okay. What about blood vessels?
Most blood vessels don't get direct parasympathetic nerves. But atropine can block the vasodilation caused by acetylcholine acting on muscarinic receptors on the endothelial cells lining the vessels, or dilation mediated by the rare sympathetic cholinergic nerves. And interestingly, at toxic doses, and sometimes even therapeutic doses in sensitive people, atropine causes that characteristic cutaneous vasodilation. The skin, especially on the face and upper trunk, becomes flushed and red. That's the red as a beet part of the poisoning picture. The mechanism isn't fully understood.
So, overall cardiovascular effect.
In a normal person, you might get tachycardia, but blood pressure usually isn't affected much. The main cardiovascular use is really to block excessive vagal effects, like those you might see during a heart attack or from certain drug exposures. It effectively prevents the effects of administered muscarinic agonists.
All right, moving on to the lungs. Breathing easier with antimuscarinics. How do they help in respiratory disease?
Well, our airways have significant vagal innervation, and the smooth muscle and glands there are rich in muscarinic receptors, mainly M3.
So blocking them should
Cause bronchodilation, relaxing the airway smooth muscle, and also reduce mucus secretion. These effects happen even in healthy people, but are much more pronounced and clinically relevant in patients with airway diseases like asthma or COPD.
Are they as good as, say, albuterol for asthma?
Generally, no. For acute asthma attacks, beta-adrenoceptor stimulants like albuterol are usually more effective bronchodilators. Also, there was a limitation with the older, non-selective antimuscarinics, like atropine itself if inhaled.
What was the limitation?
Remember those M2 autoreceptors on the nerve endings? They normally inhibit acetylcholine release. If you block those M2 receptors with a non-selective drug, you could actually increase acetylcholine release, which would then try to cause bronchoconstriction via the M3 receptors, partially counteracting the beneficial M3 blockade.
Ah, that M2-M3 balance again.
Exactly. Which is why the development of more M3 selective agents was such a big step forward for treating COPD and asthma. They give you the desired M3-mediated bronchodilation without messing with the M2 inhibitory pathway as much.
Makes sense. And historically, they were used before surgery.
Yes, quite routinely, especially when older, more irritant anesthetics like ether were used. Atropine or scopolamine would be given preoperatively to dry up secretions in the airway, reducing the risk of them being inhaled, and to prevent laryngospasm, which is a dangerous clamping down of the vocal cords.
And scopolamine had that bonus amnesia effect.
Right, which patients often appreciated. Modern anesthetics are much less irritating, so this routine use has decreased, but the principle remains important.
But inhaled versions are still key for COPD and asthma.
Absolutely critical. Drugs like ipratropium, tiotropium, aclidinium, umeclidinium, glycopyrrolate, usually delivered via inhaler or nebulizer. The aerosol route is perfect because it delivers the drug directly to the lungs where it's needed, maximizing the local concentration and minimizing the amount absorbed into the bloodstream, which reduces systemic side effects.
And you mentioned tiotropium has a long duration.
Yeah, tiotropium is notable for its very long half-life, around 25 hours, allowing for once-daily dosing. It's been shown to effectively reduce the frequency of COPD exacerbations, improve lung function, and increase patients' exercise tolerance. A real workhorse drug for COPD.
Okay, let's talk gut reactions. These drugs have pretty dramatic effects on the GI tract, right? Motility and secretions.
Oh yes, very marked effects. But it's important to realize you can't achieve a complete blockade of GI function with these drugs alone. The gut has its own complex enteric nervous system, sometimes called the second brain, and local hormones that also regulate things.
But antimuscarinics still do a lot.
Definitely. They reduce muscle tone in the gut wall and decrease the strength and frequency of propulsive contractions, relaxing the visceral walls. The net effect is usually prolonged gastric emptying time and slowed intestinal transit.
So useful for diarrhea.
Very effective for stopping diarrhea caused by overstimulation of the parasympathetic system or certain toxins. Although, interestingly, the intestinal paralysis they induce isn't usually permanent. After a few days of continuous use, the enteric nervous system often adapts and some level of peristalsis returns.
And the most common side effect here?
Almost universally, it's dry mouth. Salivary secretion is extremely sensitive to muscarinic blockade. It's often the first side effect people notice.
What about stomach acid? Weren't they used for ulcers?
They were, but they're not very effective at blocking gastric acid secretion compared to modern drugs like proton pump inhibitors or H2 blockers. You need quite large doses of atropine to significantly reduce acid, pepsin, and mucin output. Basal, fasting secretion, is blocked more effectively than secretion stimulated by food. This led to the development of those investigational M1 selective agents like ParaSympatho-Lytics, hoping to target acid secretion more specifically with fewer side effects. Though we now know M3 receptors are also heavily involved. Pancreatic and intestinal secretions, on the other hand, are largely under hormonal control, so antimuscarinics have little effect there.
Okay, moving down to the urinary tract and sweat glands. How do they affect urination?
They relax the smooth muscle on the walls of the ureters and the bladder. This decreases the normal voiding pressure and can increase bladder capacity, essentially slowing down the process of urination.
Which can be useful sometimes.
Yes, very useful for treating bladder spasms or urgency caused by inflammation, like cystitis, post-surgical irritation, or certain neurological conditions that cause an overactive bladder.
But also risky, especially in older men.
Absolutely. This is a major caution. In men who already have an enlarged prostate, prostatic hyperplasia, the relaxation of the bladder muscle combined with the obstruction from the prostate can easily lead to urinary retention, the inability to urinate. It's a common and serious problem. Also, long-term use has been associated with impotence in some men.
You mentioned M2 and M3 receptors in the bladder.
Right. M3 receptors directly mediate the contraction of the detrusor muscle, the main bladder muscle, while M2 receptors are also present and might play a modulating role. This understanding has led to the development of relatively bladder-selective M3 antagonists for treating overactive bladder.
Like which ones?
Drugs like oxybutynin, though it has significant dry mouth, trospium, which is a non-selective quaternary agent, so less CNS effect, and then the more M3-selected agents like darafenacin and sulfonisin, which offer once-daily dosing. Olteretidine and fisoterdine are also commonly used.
And if those don't work?
For refractory incontinence, injecting botulinum toxin S directly into the bladder muscle is an option. It works differently by interfering with neurotransmitter release, including ATP, which affects sensory nerve signaling.
Interesting. What about sweat glands?
Atropine effectively suppresses thermoregulatory sweating. Sweating is controlled by the sympathetic nervous system, but uniquely, the nerves releasing neurotransmitter onto sweat glands are cholinergic. They release acetylcholine, acting on muscarinic receptors.
So blocking those receptors stops sweating.
Correct, which can lead to problems with overheating. While adults usually only develop atropine fever with quite large doses, infants and children are extremely sensitive. Their surface area to volume ratio is different, and their ability to regulate temperature is less developed. Even ordinary therapeutic doses can cause dangerous hyperthermia in kids because they can't sweat effectively.
That's a really critical point for pediatric use.
Absolutely crucial. Deaths have occurred from relatively small doses in infants due to this effect.
Okay, we've seen the wide-ranging effects. Now let's focus on the positive side, the clinical applications. Where do these drugs really shine in patient care?
Well, we've touched on some already. For Parkinson's disease, they're still used as adjunctive therapy, particularly helpful for the resting tremor component. And for motion sickness, scopolamine remains a go-to, especially the transdermal patch, which provides steady relief for 48-72 hours, great for cruises or long travel.
And in ophthalmology, we discussed their use for eye exams.
Exactly. For accurate measurement of refractive error, especially in young children where you need full ciliary paralysis, atropine is sometimes still the gold standard due to its potency, although the risk of systemic effects needs careful consideration.
But for routine exams in adults,
shorter-acting agents like homatropine, cyclopentolate, or tropicamide are usually preferred because the dilation and focusing problems wear off much faster hours instead of days. Glycopyrrolate eye drops are another option with similar onset and duration to atropine.
And just for dilation without affecting focus?
For simple mydriasis, like before a basic retinal check, an alpha-adrenoceptor stimulant like phenylephrine is often preferred because it dilates the pupil without causing that troublesome cycloplegia. But antimuscarinics are also vital for treating inflammatory conditions inside the eye, like uveitis or iritis, to prevent the iris from sticking to the lens, forming synechia.
Got it. What about respiratory and cardiovascular uses in practice?
We mentioned the historical preoperative medication used less common now with modern anesthetics, but the principle of reducing secretions and preventing laryngospasm was key. The inhaled antimuscarinics, ipratropium, tiotropium, etc., remain cornerstone therapies for COPD and useful adjuncts in asthma delivered via that aerosol route to maximize lung deposition and minimize side effects.
And in cardiology.
Parenteral atropine given by injection is definitely appropriate therapy. When a patient, perhaps during a heart attack, MI, develops a marked reflex vagal discharge that dangerously slows down the SA or AV node function, impairing heart rate and cardiac output. Atropine counters that excessive vagal tone. It's also sometimes used in individuals with hyperactive carotid sinus reflexes, people who can faint just from pressure on their neck because it triggers an excessive vagal response. And that fascinating area of autoantibodies, finding autoantibodies against cardiac M2 muscarinic receptors in conditions like idiopathic dilated cardiomyopathy, Chagas disease, or Graves' disease. Yeah. These antibodies can sometimes mimic acetylcholine, potentially triggering arrhythmias like atrial fibrillation. The fact that atropine can block these effects gives us really important clues about how these diseases might progress and how receptors can be activated in unusual ways.
Really cutting-edge stuff. Now, for GI and urinary issues, you said they're obsolete for peptic ulcer disease.
Pretty much, yeah. We have much better, more targeted drugs now. But they do still have a niche role in treating traveler's diarrhea or other hypermotility states, often in combination products.
Like Lomotil.
Exactly. Atropine combined with diphenoxylate, Lomotil. In that specific case, the dose of atropine is actually very low. It's mainly included not for its own antidiarrheal effect, but rather to discourage abuse of the opioid component, diphenoxylate. The unpleasant dry mouth and blurred vision side effects make taking large amounts of Lomotil undesirable. A clever formulation trick.
Smart. And for urinary issues.
They provide symptomatic relief for urinary urgency and frequency caused by inflammatory bladder disorders like cystitis. But it's crucial to remember, if it's a bacterial infection, the underlying cause needs specific antimicrobial therapy. The antimuscarinic just helps manage the symptoms.
Can you give us that case study example again?
Sure. Think of J.H., the 63-year-old architect we mentioned, who had bothersome urinary frequency and urgency after his prostate surgery. This is often due to the bladder muscle, the detrusor, becoming unstable or overactive. An extended-release formulation of an antimuscarinic, like tolterodine or oxybutynin, could really help him by reducing those unwanted detrusor muscle spasms, giving him better bladder control, and improving his quality of life. We also know that for men with BPH symptoms, sometimes combining an alpha blocker, which relaxes the prostate, with an antimuscarinic, which calms the bladder, can be more effective than either alone.
And botulinum toxin, if those fail?
Right. For refractory cases, botulinum toxin A injections into the bladder muscle offer another approach, working by inhibiting neurotransmitter release. And while imipramine, an antidepressant with strong antimuscarinic effects, is sometimes used for incontinence in the elderly, its CNS side effects often limit its usefulness.
Okay, now for the really dramatic use, the emergency antidote for cholinergic poisoning.
Yes, this is where these drugs are absolute lifesavers. Severe cholinergic excess, whether from accidental exposure to cholinesterase inhibitor insecticides, ingestion of certain wild mushrooms, or, terrifyingly, exposure to chemical warfare nerve gases, is a profound medical emergency.
And antimuscarinics are key.
Absolutely mandatory. And specifically, a tertiary amine like atropine, not a quaternary one, because you need to treat the effects in the central nervous system as well as the peripheral muscarinic effects, right, like slowed heart, constricted pupils, gut upset, sweating.
And the doses are huge.
Massive compared to normal therapeutic use. We're talking initial doses of 1 to 2 milligrams of atropine intravenously, repeated every 5 to 15 minutes, until you see signs that the muscarinic blockade is taking effect, like the mouth becoming dry, the heart rate increasing, or the pupils starting to dilate. For really potent, long-lasting poisons like parathine insecticide or nerve gases, the patient might need continuous atropine administration, potentially requiring as much as 1 gram of atropine per day for up to 1 month in severe cases.
1 gram a day! Incredible. But this only treats the muscarinic effects, right? Not the nicotinic ones like muscle paralysis?
Correct. Atropine does nothing for the nicotinic effects, particularly the paralysis of respiratory muscles caused by cholinesterase inhibitors. That requires a different approach.
Which brings us to the cholinesterase regenerator compounds, the oximes, like pralidoxime or PAM.
Exactly. Oximes like pralidoxime work by directly tackling the poisoned enzyme. They have a high chemical affinity for the phosphorus atom that the insecticide or nerve agent has attached to the cholinesterase enzyme.
So they pull the poison off.
Essentially, yes. The oxime binds to the phosphorus, breaking the bond between the poison and the enzyme, thereby regenerating active enzyme. This works best if it's given before the poison enzyme complex undergoes a process called aging, which makes the bond permanent and irreversible.
Does pralidoxime get into the brain?
No, pralidoxime and another oxime, obidoxime, are quaternary amines, so they carry a charge and don't effectively cross the blood-brain barrier. They are great for reversing the peripheral nicotinic effects, especially the muscle paralysis of the neuromuscular junction, but they don't help with the CNS effects of the poisoning. There is an oxime called diacetylmonoxime, DAM, that does cross the BBB, but it's not available everywhere.
How is pralidoxime given?
Usually as an intravenous infusion, maybe 1 to 2 grams over 15 to 30 minutes, potentially repeated depending on the severity and duration of the poisoning. It's most effective at the skeletal muscle neuromuscular junction,
Hmm.
and importantly, it's generally not considered useful for poisoning by carbamate type inhibitors because the enzyme carbamate bond is different and tends to reverse spontaneously anyway.
Okay. And there was a third approach mentioned, pre-treatment.
Right. This is primarily relevant for anticipated exposure to lethal nerve agents, like in a military context. It involves pre-treatment with intermediate-acting enzyme inhibitors, like pyridostigmine.
How does that help?
The idea is that the pyridostigmine temporarily binds to and protects a fraction of the cholinesterase enzyme. So if a lethal dose of nerve agent comes along, some of the enzyme is already occupied and safe. But crucially, this strategy must be combined with simultaneous atropine administration to counteract the cholinergic effects of the pyridostigmine itself.
Complex strategy. Any others?
There's research into biological scavengers, using enzymes like human acetylcholinesterase or butyrylcholinesterase administered intravenously to basically sop up the poison in the bloodstream before it reaches the tissues. Butyrylcholinesterase is also being looked at for treating cocaine toxicity. These are mostly adjuncts right now.
And mushroom poisoning. How does atropine fit in there?
It depends entirely on the type of mushroom and the timing of symptoms. For rapid onset poisoning, symptoms within 30 minutes to 2 hours, often from Inocybe species, the symptoms are typically due to direct muscarinic excess. Here, a small dose of atropine, 1 to 2 milligrams parenterally, is usually very effective.
But not for all mushroom poisoning.
Definitely not. For delayed onset poisoning, symptoms appear 6-12 hours later, commonly caused by Amanita phalloides, the death cap. The main damage is severe liver and kidney injury caused by toxins called amatoxins. These toxins don't work via muscarinic receptors, so atropine is completely ineffective and irrelevant for this type of deadly poisoning.
And the irony about Amanita muscaria?
Yeah, despite having muscaria in its name, Amanita muscaria, fly agaric, often causes symptoms more consistent with atropine poisoning like delirium, agitation, flushed skin, rather than muscarinic excess. It contains different compounds like muscimol and ibotenic acid, so the name is misleading in terms of treatment.
Good distinction to make. Okay, let's talk downsides. No drug is perfect, and you call these a double-edged sword. Adverse effects and contraindications.
Absolutely. Therapeutic effects in one system easily become unwanted side effects elsewhere. The classic atropine poisoning syndrome is something every medical professional learns to recognize.
Remind us of the signs.
Profound dry mouth, widely dilated pupils, mydriasis, rapid heart rate tachycardia, skin that's hot, dry and flushed, red as a beet, plus significant CNS effects like agitation, confusion, delirium, even hallucinations. That old mnemonic really captures it. Dry as a bone, blind as a bat, red as a beet, mad as a hatter.
Sounds unpleasant, potentially dangerous.
It can be. Though, interestingly, atropine itself is often described as remarkably safe in adults, meaning lethal overdoses are rare relative to the doses sometimes needed therapeutically, like in poisoning. However, as we stressed before, it's highly dangerous in infants and children because of that risk of severe hypothermia. Doses as small as 2 milligrams have been fatal in infants.
So how do you treat an overdose?
Primarily, it's symptomatic management. Cooling measures like blankets or fans for the fever, keeping the patient calm, perhaps using diazepam if there are seizures or severe agitation. Supportive care is key.
What about using physostigmine, the cholinesterase inhibitor, to reverse it?
That used to be done more often, but it's generally discouraged now for routine atropine overdose. Why? Because physostigmine itself carries significant risks, like seizures or heart block, and good symptomatic management is usually effective and safer for atropine poisoning. If physostigmine is deemed absolutely necessary, it must be given in very small doses, very slowly intravenously, with continuous cardiac monitoring. It's not a first-line treatment.
What about overdose with the quaternary drugs?
Since those don't readily cross into the brain, you'll see the peripheral signs of muscarinic blockade: dry mouth, dilated pupils, tachycardia, urinary retention, constipation, but few, if any, CNS effects like delirium. However, quaternary agents can cause significant ganglionic blockade at higher doses, which can lead to a sharp drop in blood pressure, particularly orthostatic hypotension when standing up.
And treatment for quaternary overdose?
Logically, you'd use a quaternary cholinesterase inhibitor, like neostigmine, which also stays in the periphery, to reverse the blockade. And you might need a sympathomimetic drug like phenylephrine to support blood pressure if there's significant hypotension. And it's really worth reiterating that many other common drugs, older antidepressants, TCAs, some SSRIs, anti-anxiety meds, older antihistamines, have significant antimuscarinic activity. This can be a real problem, particularly contributing to memory and cognition issues in older patients. It's a cumulative burden effect that prescribers need to be very mindful of.
Definitely. So, who absolutely shouldn't take these drugs? Contraindications, you said they're relative, mostly.
Generally relative, yes, meaning you weigh the risks and benefits. But there are some strong ones. Glaucoma, particularly angle-closure glaucoma, is a major one. Even systemic doses can trigger an acute attack in susceptible individuals. Also, significant caution is needed in elderly men with a history of prostatic hyperplasia due to that high risk of urinary retention.
And you were very clear about acid peptic disease.
Absolutely. Non-selective antimuscarinic agents should never be used for ulcers anymore. They aren't very effective, better drugs exist, and by slowing gastric emptying, they can actually make reflux symptoms worse. It's just the wrong approach.
Okay, good summary of the risks. Finally, let's just briefly touch on those ganglion-blocking drugs. You mentioned them early on as an example of non-selectivity.
Right. They serve as a good contrast. These drugs work by blocking acetylcholine at the neuronal nicotinic receptors, located in the autonomic ganglia, the relay stations for both the parasympathetic and sympathetic nervous systems. Some block the receptor competitively, others physically block the ion channel associated with the receptor.
Any examples?
Historically important ones include tetraethylammonium, TEA, which was very short-acting. Hexamethonium, often called C6, was famously the first effective drug for treating hypertension, a real breakthrough at the time. Mecamylamine is a secondary amine, developed because it could be absorbed orally, unlike the earlier quaternary agents like hexamethonium. But their defining feature is that profound lack of selectivity. Blocking all autonomic outflow makes them useful tools for pharmacologists studying the autonomic nervous system in the lab. You can essentially switch off both branches.
But not great for patients.
Not at all. That broad blockade leads to such a wide range of undesirable effects that they have extremely limited clinical use today. Just too many side effects.
Can you quickly run through those effects?
Sure. CNS effects only really happen with mecamylamine, which crosses the blood-brain barrier, things like sedation, tremor, maybe even mental disturbances. In the eye, cycloplegia and some pupil dilation. Cardiovascular effects are dramatic. A big drop in blood vessel tone, leading to a precipitous fall in blood pressure, especially severe orthostatic postural hypotension. Heart contractility is reduced, and there's usually moderate tachycardia because the block affects the parasympathetic tone to the heart more than the sympathetic.
Wow. What else?
GI motility is profoundly inhibited, leading to severe constipation, sometimes even paralytic ileus, difficulty urinating, potentially urinary retention, impaired sexual function is common, and sweating is reduced because sympathetic cholinergic nerves are blocked. The key is that while the end organs can still respond to direct-acting drugs, like muscarinic agonists or adrenergic drugs, the body's own homeostatic reflexes, which rely on signals passing through the ganglia, are knocked out. This makes responses unpredictable and often exaggerated.
So, any use today?
About the only remaining niche is mecamylamine, used occasionally as an adjunct with nicotine patches to help reduce cravings during smoking cessation. But generally, their toxicity profile is just intolerable for most therapeutic applications.
Okay, wow. That really was a deep dive. We've gone from deadly nightshade in ancient times right down to the molecular structure of receptors and the complexities of treating nerve gas poisoning. It's an incredibly versatile, powerful, and historically rich class of drugs.
It really is, and I think what stands out is how understanding the details, the receptor subtypes, their locations, the different chemical properties of tertiary versus quaternary amines allows for the development of more targeted therapies, trying to get the benefits while minimizing those widespread, often problematic side effects. It truly highlights the intricate balance of our body's systems and how pharmacology tries to finely tune that balance.
Absolutely. So whether you're thinking about why you get dry mouth from an allergy pill, how motion sickness patches work, how COPD is managed, or the critical steps in treating certain poisonings, this knowledge about cholinoceptor-blocking drugs is just fundamental. It connects so many different areas of medicine and physiology. And to leave you with something to think about, a provocative thought perhaps. We've seen the journey from broad-acting natural compounds to more selective synthetic drugs.
Hmm.
Given the ongoing advances in precision medicine, maybe using detailed genetic information or even AI-driven drug design, how might we further revolutionize the use of cholinergic modulation? Could we develop therapies that are so precisely targeted to specific receptor subtypes and specific tissues, or even tailored to an individual's unique receptor profile, that we could harness the power of these pathways with virtually no unintended consequences? What might that future look like?